Good afternoon, everyone, and welcome to ALLEVIATE'S webinar series. Today, we'll be discussing about the role of ultrasound in diagnosis of shoulder pathology. As you all know, the importance of ultrasound, as it is as it's called a stethoscope for a pain physician, and so it's very important, and especially in shoulder pathology, picking it up, diagnosis and for intervention, it plays a very vital part. This is me, Dr. Wiquar Ahmed. I'm a consultant pain specialist at Alleviate Pain and Spine Center, Bangalore, and former consultant anesthesiologist at Aadhar Hospital, Kolhapur. So these are the projectional images of the rotator cuff, which are of prime importance for us. You can see an anterior view. You can see a sagittal, coronal sagittal, and how anteriorly and posteriorly the rotator cuffs will be seen. In this case, you can see the acromion, you can see the clavicle, coracoid process, the ligaments around the area, the subscapularis, the supraspinatus coming and attaching to your greater tuberosity. The asterisk is your biceps tendon. In the sagittal view, you can see the supraspinatus, your biceps tendon, your subscapularis anteriorly, your infraspinatus and TV spinal, and the acromion. Here posteriorly, you can see the infraspinatus and the teres. What you can appreciate here is that the facets of the greater tuberosity, where all the three, starting from your upper, middle, and lower facets, where your supraspinatus, infraspinatus, and the teres come and attach. So in pathology overview, we'll be seeing the impingement, rotator cuff pathology, cuff tendinopathies, partial thickness tears, full thickness tears, biceps tendon pathology, frozen shoulder, AC joint pathology, and a few videos to also follow after arthritis and effusion and calcific tendinopathy. So medical terminologies, where tendinitis, the condition in which the substance of the tendon is enlarged and exhibits a primary inflammatory response, and tendinosis, a chronic tendon injury with degeneration at the cellular level with no inflammation. Tendinopathy, a tendon, there's a spelling mistake there. It is tendon, a chronic tendon injury with no implication about the etiology. Impingement, here what you can importantly see is there is also a comparison with the illustrative diagrams is schematic diagram with the radiograph is you can see the acromion being flat in this. It's curved here and it's hooked. So these are the three types of acromions which can be present. So depending on which one is there and the amount of impingement, you can actually decide upon what modality of treatment we'll be going for. But ideally in a hook type and all, maybe surgical intervention might be required. So this is again a supraspinatus, how it tendinosis in cases of impingement syndrome, where you can see that the bursa is thickened. You can see that the tendon itself is quite thickened. You can see the attachment of the tendon, the area which is depicted by a curved arrow is quite thickened, where it is attaching to your upper facet of the greater tuberosity. Next is your rotator cuff pathology, the tears, how it is. This is a partial thickness tear which can extend, becoming a full thickness. Then that can extend to your anterior and posterior tendon, and there can be a rupture of that tendon. And these can further extend to your biceps and your subscap anteriorly and posteriorly into your infraspinatus, causing a massive tear. So here there are schematic diagrams with an ultrasound sonar images. So here you can see a partial thickness tear on bursal site. So what you should know is there can be a bursal site tear, there can be an intrasubstance tear, or there can be an articular surface tear. So in this, the one is acromion. The arrowhead is your bursa, subacromial subdeltoid bursa. 2 is your supraspinatus tendon. Then comes your articular cartilage. and your glenohumeral joint. So in this, you can see that there is a bursal side tear of the superior fibers, and you can see the asterisks where the fluid, hypoechoic fluid, is got collected. In this, you can see an articular surface tear where you can see the fluid being collected and cortical irregularities are present, whereas the superficial fibers are intact. Similarly, here as well, the superficial fibers are intact and there is a hypoechoic zone where you can see the fluid also being collected. Also, key is the cortical surface, which is irregular. This is an intrasubstance tear where you can see the fibers upper and lower are intact. The cortical, there's no cortical irregularities. Bursal side is also normal, but within the substance you can see a tear. So rim tear, again, you should differentiate. It looks like as though this is a calcification, but this is basically the articular few fibers are getting detached where there is a hypoechoic area with a hyperechoic central area. So this should not be confused with a calcification. Full thickness tear, sort of funnel-like it is. You can see here where your bursal and your articular surfaces both are connected, and the whole intrasubstance area is also hypoechoic. This basically is full thickness tear with retraction, and you also put measurements in your long and short axis, the length as well as the width. This is how you calculate. So this and the width as well. So whenever we are doing a scan, it's important for us to not only look at one area of the tendon, but it has to be a scanning of both anterior, posterior, the width and the length, both have to be checked. This is again a full thickness tear with herniation of the deltoid muscle, which is there. Deltoid, it's herniating, if you can see here, with the hypoechoic full thickness tear. Now we're coming to adhesive capsulitis, again a very commonly presented pathology, wherein you can see the rotator cuff interval, where you can actually make out that the soft tissue enlargement where your coracohumeral ligaments and all are enlarged. And this is your biceps tendon. As I was telling, this is again scanning near your coracoid. This is your subscapularis, and the hypoechoic area above that is your coracohumeral ligament. This again can be appreciated well with your dynamic scanning. Incomplete abduction. When you're doing see here, you can see this is start of abduction where you can see a supraspinatus, you can see the acromion, and it completely goes below your acromion on abduction. Whereas here, this is start of abduction and this is the end. It cannot go beyond. So even your external rotation is also blocked at that. Restricted external rotation, as I was telling you, this is the start of external rotation and this is the end of external rotation. But whereas in this case, you can see the subscapularis and the end of subscapular. You can see that hardly it has gone in. This is also very hallmark of adhesive capsulitis wherein your external rotation is blocked. This is a short axis view in which you can see the skin, subcutaneous tissue, deltoid muscle. The bursa is very clearly seen in short axis, supraspinatus, articular cartilage, and the bone cortex. SASD bursitis, wherein you can also see the synovial thickening there, and there's quite a lot of fluid which is accumulating. In biceps tendon pathology, you can see the angry birds on your color Doppler, which you can check. And this is in the bicipital area, the bicipital groove. There's a partial thickness of the anisotropy also plays a very important part near the biceps tendon. So it's always better to visualize it instead of simply, sometimes you might feel that there is no tendon itself. So this could be because your probe is not perpendicular, sorry. So it is very important that you do a short and long axis views. And anisotropy is a very important factor here. And this is a partial thickness tear with tenosynovitis. You can see there is some fluid, hypoechoic fluid collected around the area. In this also, you can see the hypoechoic fluid which is collected around whereas the tendon is healthy in this. Here, Very beautifully, the star points us towards the tenosynovitis, which is collected around the biceps tendon. Probably this is not at the bicipital groove. This could be a little below, but it's ideal to give a biceps injection intervention when you're doing. It should be done at the level of biceps tendon, in the bicipital groove. Sorry. This is again a short axis and long axis of how a tenosynovitis will look. This is again, as I told you, you have ruled out anisotropy and still you cannot find any tendon. You actually do a long axis and go down to your myotendinous junction, and you also can see this on physical examination, Popeye sign, wherein there is a complete rupture. This basically is a red flag for us. We will not be able to help this patient in any ways, non-surgically. This is subluxation of the biceps tendon from the groove with tenosynovitis as well. This is a glenohumeral joint effusion. Posteriorly, when you have placed, this is the glenoid labrum. This is the humeral head. And here you can see infraspinatus. And this is the area where it's collected. And this will be a spinoglenoid notch. Spinoglenoid notch. This is cortical irregularities in cases of rheumatoid arthritis. Again, the patient presenting in rheumatoid arthritis, the pain will be severe. So proper examination and your bloods have to be, all your CRP, ESR, CRP, anti-CCP all have to be followed up with it if the patient is not been diagnosed. AC joint pathology, a very superficial joint, easy to diagnose. This is a normal joint where you can see that there is a downsloping. You can see there is not much of collection there. There's no synovial hypertrophy. Your cortical erosions are not there. Whereas here in arthritis, you can see that the bony edges, you can see it's irregular. There is cortical erosion here. There is fluid accumulated. There is some synovial hypertrophy as well. In this case, there is a lot of hypertrophy, probably related with your inflammatory arthritis. There's something called as Gazer's sign, wherein you can find a sort of swelling, pseudo tumor sort of a thing which can be present near the AC joint. That happens because there's a complete rupture of your supraspinatus, and the glenohumeral joint effusion comes out through this via the bursa into the joint. That forms the tumor leg. Calcific tendinitis, again a very common presentation which can be seen, and deposition of calcium hydroxyapatite. This is the longitudinal and a short axis scan of the supraspinatus. It can be into a precalcific stage, calcific stage, or the postcalcific. That is formative and resorptive phase, wherein you can see that there is posterior acoustic shadowing initially, and then you can see that as it goes on in your grade 3 of calcification and all, wherein it is more of a semi-solid and it will be more mobile. This is your subscapularis and relation with your glenohumeral capsular complex, wherein you can see that it has got your subscapularis comes and attaches to your lesser tuberosity, and there is superficial tendinous layer and there is a capsular layer, which again gets connected into your joint. So this is again, it also shows that your subscapularis tendon is multipinnate, not to be confused with your tears. These are a few interventions. You can see this is joint implant needling in this. You can see the joint being beautifully opened up. This is again in-plane needling of the supraspinatus, partial thickness tear. Supraspinatus needling, quite a common pathology, but quite painful. So it has to be done very slowly, and needling has to be done a little bit of depositing only in one area might not help, and it has to be done very slowly because quite a painful procedure. This is again suprascapular nerve block. You can see the needle, because the needle is not parallel here, you will not be able to visualize it very clearly. This is the notch where you can see the spread. We usually give this prior to your supraspinatus or infraspinatus PRP. This is again an in-plane needling, wherein you can see the ergonomics. You can see the patient is also quite comfortable. We've given a block. You can see the needle there in plane. You can see the supraspinatus there. This is a case of frozen shoulder, posterior joint line. You can see the labrum. You can see in-plane needling. The labrum in this case. Here again, you'll be able to visualize hydrodilatation of the shoulder joint, which we have done for frozen shoulder. You can see the distension, and you can see the humeral head being it's pushed down. And your infraspinatus is pushed up, and you can see that the spread of your local and NS into the joint. These are my references. Hope it was useful. Thank you very much.